Pharmacodynamics, drug receptor interaction, and dose-response curves. Welcome to PharmaconHealth. Today, we're diving deep into pharmacodynamics, the branch of pharmacology that explains how drugs produce their effects in the body. We'll focus on how drugs interact with their targets, called receptors, and how we measure these effects using dose-response relationships. Now that we've set the stage, let's explore the fundamentals of pharmacodynamics, how drugs interact with receptors, and how those interactions lead to biological effects. What is pharmacodynamics? Pharmacodynamics is the science of what a drug does to your body. It explains how drugs cause changes in your cells and tissues to produce effects. Whether that's pain relief, lowering blood pressure, or fighting infection, it's different from pharmacokinetics, which is about how your body processes the drug. Here, we focus on how drugs interact with specific targets called receptors, and how those interactions create a biological response. Understanding this helps prescribers decide how much drug to give and what effects to expect. Now, let's take a closer look at the main types of targets drugs act on in the body. Primary drug targets, receptors, enzymes, and more. Drugs work by binding to specific targets in the body. Most commonly, these targets are receptors, special proteins on or inside cells that recognize molecules and trigger effects. There are different types of receptors, including G-protein coupled receptors and ion channels. But receptors aren't the only targets. Drugs can also act on enzymes, which speed up chemical reactions. They may target transporters, which move substances across cell membranes, and in some cases, drugs act on structural proteins or even DNA, though that's less common. Where and how a drug binds determines what it will do. Now, let's move on to drug receptor interaction. Drug receptor interaction. Think of a receptor like a lock, and a drug like a key. For the drug to work, it must fit the receptor just right. This is called the lock and key model, but sometimes the receptor changes shape slightly when the drug binds. That's the induced fit model. Two important concepts here are affinity and efficacy. Affinity means how tightly the drug binds to the receptor, like how well the key fits into the lock. Efficacy, also called intrinsic activity, is about what happens after binding. Does the key turn the lock to open the door and start an effect? Or does it just fit, but not work? Some drugs bind well, but do not activate the receptor. Others bind and strongly activate it. Now, let's look at the different receptor families. Receptor families as drug targets. There are four main types of receptors that drugs act on. First, ligand-gated ion channels. They respond quickly by opening or closing to let ions move in or out of the cell. This changes the electrical activity of the cell within milliseconds. Second, G-protein coupled receptors. They activate internal messenger systems through helper proteins called G-proteins. These signals often affect many parts of the cell and may last longer. Third, enzyme-linked receptors. These activate enzymes inside the cell. They often work by adding phosphate groups to proteins, triggering a chain of reactions that changes cell behavior. Fourth, nuclear receptors. These are found inside the cell. They enter the nucleus and change how genes are expressed. This leads to slower but long-lasting effects, like new protein production. Each of these receptor types has a unique structure and a unique way of producing effects. Understanding them helps explain how different drugs work. Now, let's take a closer look at the first type, ligand-gated ion channels, or LGICs. Ligand-gated ion channels, or LGICs, also called ionotropic receptors. They act very fast, usually within milliseconds, when a drug or natural ligand binds to the receptor. It causes the ion channel to open. This allows charged particles, or ions, such as sodium, potassium, or calcium, to flow into or out of the cell. This movement of ions changes the electrical charge of the cell membrane and triggers immediate effects, like muscle contraction or the transmission of nerve signals. These receptors play a key role in fast signaling in the nervous system and muscles. Examples include the nicotinic acetylcholine receptor, which is important in muscle contraction, and the GABA receptor, which helps slow down brain activity by sending inhibitory signals. Now, let's focus on one of the most well-known ligand-gated ion channels, the nicotinic acetylcholine receptor. Ligand-gated ion channels. Nicotinic acetylcholine receptor. A key example of ligand-gated ion channels is the nicotinic acetylcholine receptor. Found at the junction where nerves connect two muscles, when acetylcholine binds to this receptor, it opens channels that allow sodium ions to enter and potassium ions to exit the muscle cell. This changes the electrical charge of the muscle, causing it to contract and enabling movement. Some drugs and toxins target this receptor to either stimulate or block muscle activity, while ligand-gated ion channels produce very fast responses. Another important class of receptors, G-protein-coupled receptors, or GPCRs, work differently. They activate slower, longer-lasting signaling pathways inside the cell. Let's take a closer look at how GPCRs function. G-protein-coupled receptors, or GPCRs. GPCRs are the largest and most diverse family of receptors. They span the cell membrane 7 times. When a drug or natural ligand binds to a GPCR on the cell surface, it activates a nearby G protein inside the cell. This activated G protein then starts a cascade of signals by producing molecules called second messengers. These messengers carry the signal deeper into the cell, affecting many different cell functions. Examples of GPCRs include beta-adrenergic receptors, which help regulate heart rate, and dopamine receptors, which play key roles in mood and movement. Next, we'll explore one important signaling pathway triggered by GPCRs, the secondary messenger system involving cyclic AMP, or CAMP. GPCR secondary messenger systems. CAMP pathway. One common signaling pathway activated by GPCRs is the CAMP pathway. When a G protein called GS is activated, it turns on an enzyme called adenylate cyclase. This enzyme converts ATP, the cell's energy molecule, into cyclic AMP, or CAMP. CAMP acts as a messenger inside the cell, activating an enzyme called protein kinase, or pKa. pKa then adds phosphate groups to other proteins, changing their activity and producing the cell's response. For example, this pathway increases heart rate when adrenaline binds to beta-adrenergic receptors. Next, let's look at another important GPCR signaling pathway, the IP3 and DAG pathway. GPCR secondary messenger systems. The IP3 and DAG pathway. Another important signaling pathway involves a G protein called G. When GQ is activated, it turns on an enzyme called phospholipase C, or PILK. This enzyme breaks down a membrane lipid called PIP2, short for phosphatidylinositol for 5-bisphosphate. PIP2 is split into two messenger molecules, IP3 and DAG. IP3 stands for inositol trisphosphate. DAG stands for diacylglycerol. IP3 travels inside the cell to the endoplasmic reticulum. There, it triggers the release of calcium ions into the cytoplasm. Calcium ions, together with DAG, activate an enzyme called protein kinase C, or PKC. PKC modifies proteins to produce effects like muscle contraction or cellular secretion. Enzyme-linked receptors. Overview. These receptors are found on the surface of the cell and are activated when a signaling molecule binds to them. Once activated, they trigger an enzyme activity inside the cell. The most common type is the receptor tyrosine kinase. When activated, it adds phosphate groups to certain proteins. This process is called phosphorylation. Phosphorylation changes how proteins behave and helps send signals inside the cell. This type of receptor controls important processes like cell growth, division, and survival. Problems in these signaling pathways can lead to diseases like cancer. Let's now take a closer look at how receptor tyrosine kinase works in detail. Enzyme-linked receptor signaling. Phosphorylation and cascadation. A ligand binds enzyme-linked receptors often pair up or dimerize. This activates their enzyme parts, leading to autophosphorylation, adding phosphate groups to themselves. These phosphate groups act like docking stations, attracting proteins inside the cell that start a chain reaction of phosphorylation. One important chain reaction is the MAP pathway. MAP stands for mitogen activated protein. It is a chain of proteins that send signals inside the cell to control processes like growth and division. These reactions amplify the signal and result in changes like cell division or increased metabolism. Nuclear receptors overview and mechanism. All receptors are located on the surface of cells. Nuclear receptors are found inside the cell, either in the cytoplasm or directly within the nucleus. They bind molecules that are lipid-soluble, meaning they can easily pass through the cell membrane. Common examples include steroid hormones like cortisol, estrogen, and thyroid hormone. When such a molecule, called a ligand, enters the cell and binds to the nuclear receptor, the receptor changes its shape. If it's in the cytoplasm, it then moves into the nucleus. Inside the nucleus, the receptor binds to specific DNA sequences called hormone response elements. This binding either activates or suppresses the transcription of target genes. As a result, the cell increases or decreases the production of certain proteins. These changes happen more slowly than with membrane receptors, but they often lead to long-term effects, such as regulating metabolism, growth, or stress responses. Example, cortisol affects genes that control inflammation and immune function. Another example, thyroid hormones increase the production of proteins that regulate energy use in cells. Now that we've explored how different types of receptors function, including nuclear receptors, let's look at the fundamental principles that explain how drugs interact with these receptors. This brings us to receptor theory, the foundation of pharmacodynamics, including both basic concepts and advanced models used to predict drug behavior. Receptor theory. Basic concept and advanced models know that we understand how receptors work, including nuclear receptors. Let us explore an important concept in pharmacology called receptor theory. This section explains how drugs produce their effects by interacting with receptors. We will cover both classical ideas and modern models, including how drugs bind, how they activate or block receptors, and why different drugs can cause different responses even when they target the same receptor. Let us begin with the basic concept of drug-receptor interaction. Many drugs work by binding to receptors. Receptors are special protein molecules found on the surface or inside of cells. They act like locks that control certain biological functions. Drugs are chemical substances that act like keys that fit into these locks. When a drug binds to its target receptor, it can trigger a specific response in the cell, like opening a channel, activating a signal, or turning on a gene. Example, salbutamol is a common inhaler drug for asthma. It binds to beta-2 receptors in the lungs. This causes airway muscles to relax and makes breathing easier. 12. Receptor occupancy theory. This classical theory says the strength of a drug's effect depends on how many receptors it binds to. If only a few receptors are occupied, the response will be small. As more receptors are occupied, the response becomes stronger until a maximum effect is reached. Example, adrenaline works this way. At low doses it slightly increases heart rate. At higher doses it binds more receptors, leading to a stronger response like rapid heartbeat and high blood pressure. Other spare receptors. Some drugs can produce their full effect without binding to all receptors. In these cases, extra and news receptors are called spare receptors. They act as a buffer, making the body more sensitive to the drug. Example, insulin can lower blood sugar effectively. Even if it binds to only a fraction of insulin receptors, the body does not need all receptors to be occupied to achieve full glucose uptake. For different levels of receptor activation, not all drugs behave the same after they bind to a receptor. Their effects depend on how much activity they produce once they are bound. There are four main types of drug action agonists. These bind to receptors and fully activate them. Example, morphine binds to opioid receptors in the brain and spinal cord. It relieves pain by producing a strong response. A partial agonist. These bind and activate receptors only partially. Even if all receptors are occupied, the response is weaker than a full agonist. Example, buprenorphine binds to opioid receptors but produces a moderate pain relief. It is used in addiction treatment because it has a ceiling effect and is less likely to cause overdose. Antagonists. These bind to receptors but do not activate them. Instead, they block the receptor and prevent other substances from binding. Example, propranolol binds to beta receptors in the heart. and prevents adrenaline from acting. This helps reduce blood pressure and heart rate. Inverse agonists, these bind to receptors and reduce their baseline activity below normal. Example, famotidine binds to histamine H2 receptors in the stomach. It lowers acid production more effectively than just blocking the receptor. The two-state model. This model says receptors naturally exist in two states: an inactive state where nothing happens, and an active state where a cellular response is triggered. Even without a drug, receptors can switch between these states at random. Drugs influence this balance. Agonists shift more receptors into the active state, increasing the response. Antagonists bind without activating, keeping receptors in the resting state. Partial agonists produce some activation, but less than full agonists. Inverse agonists push receptors toward the inactive state, reducing activity even further. This model explains why different drugs acting on the same receptor can produce different effects. So far, we have learned how drugs interact with receptors and how different types of drugs such as agonists, partial agonists, antagonists, and inverse agonists produce different responses. But not all antagonists behave the same way. Some can be pushed aside by increasing the dose of the agonist. These are called competitive antagonists. Others block the receptor in a way that cannot be overcome no matter how much agonist is given. These are called non-competitive antagonists. To understand this better, let us now explore how different types of drugs bind to receptors. We will focus on agonists, partial agonists, and antagonists, and examine how their actions determine the final biological response. Receptor drug binding. Agonists, partial agonists, and antagonists. Drugs that act on receptors can behave very differently depending on how they affect those receptors. Some drugs fully activate the receptor and create the strongest possible effect. These are called agonists. Take salbutamol, for example. It is a beta-2 agonist used for asthma. When it binds to beta receptors in the lungs, it tells the airway muscles to relax. This makes it easier for the person to breathe. Salbutamol shows us what a full agonist, as it activates the receptor completely to produce a clear therapeutic response. No, not all drugs go that far. Some drugs still bind to the receptor, but only partially activated. These are known as partial agonists. One well-known partial agonist is buprenorphine. It is used in the treatment of opioid addiction. When it binds to opioid receptors, it sends a weaker signal than a full agonist, but that weaker signal is enough to reduce withdrawal symptoms, and it comes with a lower risk of overdose. This makes buprenorphine a safer option in many clinical situations than there are drugs that bind to receptors but do not activate them at all. These are called antagonists. They act more like blockers. They sit on the receptor and prevent other activating drugs from getting in. Propranolol is a good example. It binds to beta receptors in the heart and stops adrenaline from having its usual effect. This helps lower blood pressure and slow the heart rate. Another example is naloxone. It is used in emergency medicine to reverse opioid overdose. It blocks opioid receptors quickly and stops the dangerous effects of drugs like morphine or heroin. The way these drugs behave is linked to a concept called intrinsic activity. This refers to the drug's ability to activate the receptor once it is bound. Agonists have high intrinsic activity because they fully turn on the receptor. Partial agonists have moderate intrinsic activity because they produce only a limited response, and antagonists have zero intrinsic activity. They bind to the receptor but do nothing to activate it. By understanding this idea, we can better explain how different drugs either stimulate, reduce, or block biological effects, and why this matters in choosing the right drug for the right condition. So now that we have seen how agonists, partial agonists, and antagonists work, let us take a closer look at how antagonists differ from each other, especially when it comes to competitive and non-competitive receptor blockade. Mechanisms of receptor blockade. Competitive versus non-competitive antagonism. Antagonists can block receptors in different ways depending on how they bind. Competitive antagonists bind reversibly to the same site on the receptor as the agonist. They compete directly with the agonist for that spot because the binding is reversible. If you increase the dose of the agonist, you can overcome the effect of the competitive antagonist. Competitive antagonists work differently. They either bind irreversibly to the same site or attach to a different site on the receptor. This prevents the receptor from responding no matter how much agonist is present. Because of this, non-competitive binding reduces the maximum response. the drug can produce. Understanding how antagonists block receptors is important, but it is only part of the story. Cells can also adapt to continuous stimulation by changing how sensitive their receptors are or by adjusting the number of receptors they have. This process is called receptor desensitization and regulation. It plays a key role in how drugs work over time. And let's explore how receptors become less responsive and how the body adjusts when exposed to drugs for a long time. Receptor desensitization and regulation. Receptors don't always respond the same way over time. If they are stimulated continuously, their response can decrease. This is known as desensitization. There are two main types of desensitization. Homologous desensitization occurs when only the stimulated receptor becomes less responsive. For example, repeated use of beta agonists, like salbutamol, can reduce beta receptor responsiveness. In contrast, heterologous desensitization affects multiple receptor types. For instance, chronic stimulation of one receptor may reduce the responses of other receptors as well. The body can also reduce the number of receptors. This is called downregulation. A good example is chronic exposure to high insulin levels, which leads to fewer insulin receptors in cells. Conversely, when receptors are blocked by antagonists, the body may increase receptor numbers. This is called upregulation. For example, prolonged use of beta blockers, like propranolol, can lead to an increase in beta receptor production. These are adaptive mechanisms. They help the body adjust to drugs and explain how drug effects can change over time. But that's not the whole story. Some people respond differently to the same drug due to genetic differences in receptors. This is known as receptor polymorphism. Next, we'll explore how genetic variation influences drug response and why the patients can react very differently to the same medication. Receptor polymorphisms and individual variability. Every person's body is unique, and this includes their receptors, the proteins drugs bind to. Small differences in the genes that code for these receptors are called polymorphisms. These genetic variations can change the shape or function of a receptor. Because of this, drugs may bind better or worse in different people. For example, some people have variations in the beta-2 adrenergic receptor gene that affect how well asthma drugs like salbutamol work. Similarly, variations in opioid receptor genes can change how patients respond to pain medications like morphine. These differences mean some patients may have a stronger response to a drug, while others may see little benefit. Some people may also experience side effects that others do not. Understanding receptor polymorphisms is very important in personalized medicine. Personalized medicine aims to tailor treatments to each individual's genetic makeup. This approach helps choose the right drug and dose for the best effect, with fewer side effects. Genetic differences in receptors help explain why people respond differently to the same drug, but receptors aren't the only drug targets in the body. Next, we'll explore another important class of targets: transporters, which move substances across cell membranes and are often involved in drug action. And resistance. Transporters, gatekeepers of drug movement. Transporters are special proteins found in the membranes of cells. They help move molecules in and out of the cell. Some drugs work by blocking or using these transporters to control the movement of substances. For example, antidepressants like SSRIs block serotonin transporters. This keeps serotonin in the synapse longer and improves mood. Transporters play a key role in drug absorption, distribution, and elimination. While transporters help move substances across cell membranes, drugs can also act on structural proteins, the components that maintain cell shape and function. Let's take a look at how targeting structural proteins can affect processes like cell division and cancer treatment. Structural proteins. Cellular framework disruptors. Structural proteins give cells their shape and support. They are part of the internal skeleton of the cell. Some drugs bind to these proteins and interfere with their function. A well-known example is paclitaxel, a chemotherapy drug. It binds to tubulin and stops cells from dividing. This is useful in treating rapidly growing cancer cells. Besides proteins, nucleic acids like DNA and RNA can also be drug targets, though less common. Targeting nucleic acids can be powerful, especially in cancer and infectious disease treatment. Let's explore how drugs interact with DNA to block cell growth or Kill harmful cells. Nucleic acids. Rare but critical drug targets. Nucleic acids include DNA and RNA inside the cell nucleus. They store the cell's genetic information, although they are not common drug targets. Some drugs act directly on DNA. For example, doxorubicin is a chemotherapy drug that binds to DNA. It prevents the DNA from copying, which stops cell division. This is especially useful in targeting cancer cells. Targeting nucleic acids causes strong effects, but also has higher risks. Now let's move on to explore the types of dose-response curves, graded versus quantile responses, and understand how drugs produce effects at different doses. Types of dose-response curves. Graded versus quantile. Drugs produce different types of responses in the body. We use dose-response curves to measure these effects. There are two main types of dose-response curves. First is the graded dose-response curve. Graded curves measure effects that change in intensity. For example, how much a drug lowers blood pressure on the graph. The dose is on the horizontal axis. The size of the effect is on the vertical axis. Two important values are EC50 and Emax. EC50 is the dose that produces half the maximum effect. Emax is the maximum effect the drug can produce. These values help us understand drug potency and efficacy. Second type is the quantile dose-response curve. Quantile curves measure all or none effects. For example, whether a patient has a seizure or not instead of effect size. This curve shows the percentage of people who respond at each dose. Important parameters include ED50, TD50 and LD50. ED50 is the dose effective in 50% of people. TD50 is the dose that causes toxicity in 50% LD50 is the lethal dose in 50% of the population. These parameters help define safe and effective drug doses. Understanding these curves is key to drug development and clinical use. Know that we've covered graded and quantile dose-response curves. Let's focus on two important drug properties: potency and efficacy, and learn how these concepts help us compare drugs. Potency versus efficacy. Potency and efficacy are two important but different concepts in pharmacology. Potency tells us how much of a drug is needed to produce an effect. A drug that requires a lower dose to produce the same effect is more potent. We measure potency using values like EC50 or ED50. The dose that produces half the maximum effect, or response. Efficacy refers to the maximum effect a drug can produce regardless of dose. A drug with higher efficacy can produce a stronger or more complete response. Potency and efficacy are not always linked. Some drugs may be very potent but only produce moderate effects. Others may have high efficacy but require higher doses. Understanding both potency and efficacy helps in choosing the right drug for a patient. Know that we understand potency and efficacy. It's important to realize that dose-response relationships can be influenced by many factors. These include things like patient age, genetics, disease state, and drug interactions. Let's explore these factors next to see how they affect drug response. Factors affecting dose-response relationships or factors influence how drugs produce effects at different doses. Understanding these is critical for accurate dosing and predicting drug responses. Body size. Body size affects the volume of distribution and drug clearance. Larger individuals may require higher doses of drugs like digoxin or lithium because the drug spreads into a larger body mass. Age. Age impacts drug metabolism and organ function. Infants and elderly patients often metabolize drugs more slowly, increasing sensitivity and risk of toxicity. For example, elderly patients may need lower doses of benzodiazepines to avoid excessive sedation. Sex. Biological differences, such as hormone levels and body fat, can affect drug kinetics. Women may experience stronger effects from opioids due to differences in metabolism and receptor sensitivity. Species and race. Genetic differences between species and among human races can affect drug metabolism and receptor response. For example, warfarin dosing varies among ethnic groups because of genetic factors. Genetics. Individual genetic makeup changes drug metabolizing enzymes and receptor structures. People with certain CYP to D6 gene variations metabolize codeine differently, affecting its safety and effectiveness. Route of administration. How a drug is given affects absorption and bioavailability. Oral nitroglycerin undergoes first-pass metabolism in the liver, making it less effective than sublingual administration. environmental factors, and time of administration, diet, chemical exposures, and timing influence metabolism. Taking statins in the evening aligns with peak cholesterol production and improves effectiveness. Psychological factors. Patient expectations can influence drug responses. The placebo effect can increase pain relief in patients taking analgesics. Pathological states. Diseases such as liver or kidney impairment alter drug metabolism and excretion. For example, aminoglycoside doses must be adjusted in patients with kidney failure. Other drugs given together, drug interactions can enhance or block drug effects. Combining MAO inhibitors with certain antidepressants can cause dangerous reactions. Tolerance. Repeated use of some drugs, like morphine, decreases responsiveness, requiring higher doses to achieve the same effect. Understanding these factors helps tailor drug dosing for safe and effective treatment. Next, we will summarize the fundamentals of pharmacodynamics, how drugs act on the body. To summarize, pharmacodynamics helps us understand how drugs produce effects by interacting with receptors. Dose-response relationships provide important insights into a drug's potency and efficacy. Different receptor families activate unique signaling pathways, explaining the wide variety of drug actions. Finally, many factors influence how drugs work in the body. This knowledge is essential for safe and effective therapy. Thank you for joining us today. Please subscribe and stay tuned for more in-depth pharmacology lessons from PharmaconHealth.